even modest reductions in blood pressure translate to clinically important reductions in major adverse events.
Welcome to Living Real Change, a podcast from Piedmont Healthcare. I'm your host, Dr. Lacey Knight, Chief Health Information Officer here at Piedmont. Join us as we highlight the people, the stories, and ideas that are transforming care and strengthening communities across Georgia. From inspiring patient journeys to expert health advice, each episode offers insight, hope, and a closer look at what real change looks like in healthcare today. Hypertension, also known as high blood pressure, is one of the most common health conditions worldwide, affecting nearly 1 in 2 adults in the United States and serving as a major contributor to conditions like stroke, heart attack, and heart failure. Dr. David Kandzari, Chief of the Piedmont Heart Institute and Chief Scientific Officer for Piedmont Healthcare, explains what high blood pressure really is, why even modest improvements can significantly reduce risk, and how proper measurement helps guide care. He walks us through today's treatment approaches, from lifestyle changes and medications to newer therapies for resistant hypertension, and shares why knowing and tracking your numbers is one of the most important steps in preventing long-term complications. David, it's great to have you with us today.
Thanks, Lacey. Thanks for having me for this opportunity.
First question is, how did you develop an interest in cardiology, high blood pressure, all of those types of things? Maybe you could give us a little bit about your journey to where you are today.
Certainly. My journey with hypertension begins really as a medical student, given the prevalence of hypertension. Hypertension is the global leading cause of death and disability worldwide. And still in the United States alone, while hypertension affects 1 in every 2 adults, as we'll discuss further, more than 75% of individuals with hypertension do not meet societal or guideline recommended blood pressure treatment goals. And so my experience with hypertension, like all healthcare providers, really began probably with my first or second patient, and it's evolved over more than a 25-year period, but in particular over the past 10 to 15 years, through research and with the development of novel therapies to treat hypertension that previously have not been considered to treat really what is a worldwide epidemic.
What is hypertension or high blood pressure? If we break it down very simply, what does that actually mean?
So specifically, to date, hypertension is defined as having a blood pressure that's greater than 130 systolic, the top number, or greater than 80 millimeters mercury diastolic. For patients with what's termed treatment-resistant hypertension, these are individuals with a blood pressure greater than 140/90, despite treatment with 3 or more medications to treat high blood pressure, and this is unfortunately quite commonplace too. But our guidelines, our societal goals for treating blood pressure have moved towards lower benefits because what's often overlooked in routine clinical practice is that even modest reductions in blood pressure translate to clinically important reductions in major adverse events that include death or stroke or heart attack. For example, for every 10 millimeter mercury, we reduce the systolic blood pressure. So for example, going from 170 to 160 or 150 to 140, for every 10 millimeter reduction, we achieve an approximate 10 to 15% reduction in death alone, and about a 25 to 30% reduction in events that are, put simply, irreversible, such as stroke or heart failure or heart attack. And there's even more evolving data that's suggesting the contribution of uncontrolled high blood pressure to dementia and cognitive decline. So even modest reductions in blood pressure are still quite meaningful.
It sounds like there's a lot to be optimistic about. If you have high blood pressure, just lowering it even a little bit makes a big difference. Can you explain what's happening in kind of layperson's terms with the top number and the bottom number? Is one more important than the other one?
That's a great question, and it's often asked by many patients. Patients may have what we term isolated systolic hypertension, where the top number, the systolic number, is elevated and the bottom number still remains within a normal range, the diastolic value. Alternatively, other patients may have what we call combined hypertension, where both the systolic, the top number, and the diastolic bottom number are both elevated. In both instances, this poor control of blood pressure portends a bad prognosis. But overall, and while both the systolic and the diastolic values, when elevated, contribute to irreversible end organ damage and adverse events, as we've discussed, probably there's greater focus on treating the systolic number, the top number, rather than exclusively the diastolic number as well. And for people with combined hypertension, that is elevated systolic and diastolic blood pressure, typically when we focus on treating the systolic value, the diastolic value also declines.
A lot of people think that it's because we're eating too much salt. Is that a primary influence on whether or not folks have high blood pressure? Are there other things like genetics or lifestyle components that contribute to high blood pressure?
Yes, and the short answer is all of the above. And lifestyle can add to the contribution of genetics and inheritance as well. For many people, as we age and as we've discussed, our arteries within our bodies become less elastic, leading to the development of hypertension. But still, for many other individuals, we have a higher, what we call sympathetic signature, or higher drive of adrenaline within our bodies that's contributing to high blood pressure. And many, both drug and device therapies for the treatment hypertension, are now targeted toward that. There are also less common, what we call secondary causes of hypertension, and these may be due to thyroid or hormonal disorders, other endocrine disorders as well, certain rare types of tumors that can contribute to high hypertension, blockages from cholesterol buildup in the kidney arteries. So when we do an evaluation for patients with difficult to control hypertension, we oftentimes look for these other less common causes of high blood pressure. With regard to salt intake, though, you're absolutely right. For not for all patients, but for many individuals with high blood pressure, salt intake, sodium intake specifically, contributes to high blood pressure as well. And this is evident in at least 40% of individuals who have high blood pressure. And so, lack of exercise, an inappropriate diet, high salt intake, smoking certainly are all features that contribute to hypertension as well. And while no identifiable genetic basis or genetic marker has been identified for the contribution of hypertension, to be sure, there are individuals who have and different ethnic groups who seemingly have very high levels of a high prevalence of hypertension as well.
Thank you for that. Let's talk about a diagnosis and even measurements. How is high blood pressure diagnosed?
High blood pressure is diagnosed by simply measuring one's blood pressure, and this can be done in an office setting, it can be done at a fire department, it can be done in the home setting. What's very important too, however, is that when individuals are diagnosed with hypertension, that they continue to monitor their blood pressure at home as well. I often describe your taking your blood pressure in the clinic setting, in the office setting, as a selfie with a cell phone. And what happens is that, well, first of all, that selfie, that picture, that blood pressure measurement is what you look like just at that moment, not 5 seconds before, not 5 minutes later, but just at that moment. And if you repeat the blood pressure, you're going to get a different value. And if you don't like the blood pressure, what does the doctor do? He or she oftentimes repeats the blood pressure until they find a value that they really like. And that's exactly what we do with selfies, right? If we don't like the picture, we just keep taking it till we find something better. But the bottom line is that the more data points you have, the more informed you're going to be with regard to your hypertension burden. That is the extent of of high blood pressure that you're experiencing. And specifically, we want the blood pressure on average to be under 130/80. And the more data points we have, the better estimates we can provide, the more informed we are about what that average is. If I took the blood pressure just 2 times, I might get a very erroneous measure that might not be representative of what really that patient is experiencing 24/7.
Just to follow up with that, a lot of patients are nervous when they first get to the physician's office, especially if they don't go very often. This concept of white coat syndrome, can you talk about what that is? And then also explain how you make distinguish between white coat hypertension and chronic high blood pressure?
Great question. White coat, so termed white coat hypertension, just as you described, when the individual goes to the doctor and the blood pressure is high, and yet the patient says, but at home, my blood pressure is always normal. It turns out that probably in more instances than not, whether that individual is late for a meeting or in traffic or at other times, they're also experiencing these surges of high blood pressure, not just, of course, in the presence of a healthcare provider. And it turns out, however, that if we look at the spectrum of risk of hypertension, those individuals at the highest risk of death from hypertension or end organ failure, kidney failure, stroke, heart attack with hypertension are individuals with both daytime and nighttime hypertension. That is, they are hypertensive throughout the 24-hour period. But along the spectrum, even those individuals with so-termed white coat hypertension are even at higher risk for adverse events compared with patients who are normotensive, that is, who do not have high blood pressure at any time point. So it's somewhere intermediate in the risk with regard to the spectrum of risk with regard to hypertension. And how we identify or parcel out those types of patients can be done by either home blood pressure monitoring, as we've discussed, or also we have what's termed a 24-hour ambulatory blood pressure monitoring, where we can place a blood pressure cuff on the arm that inflates and deflates every 30 minutes during the waking hours, every hour during the sleeping hours over a 24-hour period. And we really understand the true trajectory of blood pressure over a 24-hour period for an individual. We really assay the hypertension burden for an individual as well, and whether they're hypertensive at just one moment throughout the day or perhaps at all moments.
That is interesting. With regards to home monitoring, how often do people get it right? How often do they make mistakes and create some inaccurate reading? And what is the proper way to measure one's blood pressure at home?
This is a terrific question because it's something that we always want to instruct our patients. If we're asking them to do the monitoring, we need it to be accurate. And in most instances, patients get home blood pressure monitoring fairly accurate. And to begin with, if there's ever any uncertainty with regard to the accuracy of their home monitoring device, we always ask patients to take it in to the clinic or to take it into a fire department, for example, too, and just do a simple measurement and confirm with a manual blood pressure reading with the accuracy of their device. But in general, contemporary devices for home blood pressure monitoring are fairly accurate. And the advantage, too, is that many of them can even send to your cell phone, for example, a whole database of blood pressure readings that the individual in the clinic setting can share with his or her doctor. The key pitfalls for home blood pressure monitoring really involve perhaps just two or three items. One is that in general, arm cuffs over the biceps are more accurate than wrist cuffs. Secondly, the individual, when measuring blood pressure, we want them to do it. It doesn't have to be at the exact same time every day at 9:30 every morning, for instance, but generally at a similar time period. And when they're not rushed, when they're relaxed and they're not, late for going to work, for example, or fighting traffic. And we want them to do it in a sitting position with both feet on the ground, that is, not having the legs crossed. And the last item, which can be a shortfall in the measurement of blood pressure, has to do with the size of the cuff. It's very important that we have the appropriate size cuff for an individual. So, for example, a very large man or with a large bicep arm may require a much larger cuff because a smaller cuff will overestimate the blood pressure. And conversely, a very small individual may require a smaller sized cuff.
At Piedmont, quality care changes lives. Meet Tom, a lifelong medic who suddenly suffered a stroke at home. Tom was diagnosed, treated, and in surgery within minutes, thanks to seamless coordination across the entire care team.
I've seen firsthand how every second counts. When I needed help, Piedmont moved with speed and precision, and that saved my life. A week later, I was back at home with my family, back to work and back to living.
Hear more at piedmont.org/quality care. Piedmont, real change lives here.
You mentioned this earlier, but the hypertension can be called a silent killer. There are also, I think, people who have mentioned that they can tell when their blood pressure is up. Is it true that people can always tell when their blood pressure is elevated? What does this silent killer mean? Is it really possible to have dangerously high blood pressure and not even know it?
Very much so. In many instances, hypertension is an asymptomatic illness until an irreversible event such as a stroke or a heart attack or death ensues, or kidney failure ensues. And so, yes, while many individuals can feel surges in blood pressure or may feel poorly when their blood pressure is exceptionally high, we're all wired differently, and there are great number of individuals with hypertension that is uncontrolled who are asymptomatic with it.
You mentioned the end organ damage, the kidneys and the brain. Those things are unfortunate outcomes of untreated high blood pressure. How long does it take for that type of damage to occur with elevated blood pressure? And how do people typically learn that there's been damage done to these organs?
Unfortunately, many individuals learn about the consequences of their poorly controlled high blood pressure when they're experiencing an event. And those events are often, again, not reversible, such as heart failure with a weakening of the heart, or a stroke, or kidney failure. And typically, these events occur after a period of exposure to high blood pressure within the body over several years. It goes without saying that some individuals, however, who have what we term a hypertensive crisis, where there is a very high surge in blood pressure, sometimes values going to over 200 systolic that require hospitalization. This can contribute to more acute, immediate end organ damage, such as kidney failure or stroke or a heart attack as well. So hypertension contributes to irreversible adverse events, both over the long term, but it can also be acute as well. And one of the very important issues is that many individuals who present to emergency rooms are oftentimes with very severe hypertension, are oftentimes discharged with maybe a prescription for one or no medications for their blood pressure. And this contributes to the overall poor control we have nationwide in high blood pressure. But expectedly, almost two-thirds of individuals who present to an urgent care clinic or to an emergency room with a hypertensive crisis still have poorly controlled high blood pressure 6 months later.
So it sounds like one of the big messages that you've said in a number of ways is just make sure people know what their numbers are.
It couldn't be said better. That's right. And what we're now thinking about too, in terms of blood pressure control, is somewhat analogous to how we've thought about blood sugar control for diabetics for many years. That is, at one time, many years ago, individuals would prick their finger and test their blood sugar. Now we have continuous monitors that can track your blood pressure every second of the day throughout a 24-hour period. And now, with approaching more wearable devices that could track blood pressure, more continuous monitoring opportunities, we're starting to think about blood pressure not as a single point measurement like in a clinic setting, but over an entire 24-hour period, over a month's period, perhaps over a year. And we're thinking about how much time an individual spends in what we call therapeutic range. That is, how much time that they are living under the blood pressure of 130 over 80.
And do we know yet that the amount of time that they're living within target impacts outcomes?
Very much so. We have ample data that shows that the greater time spent in therapeutic range, or what we call the greater time spent in target range, is linearly associated with a lower risk of death, of stroke, and of heart attack.
Thank you. Let's talk about the treatment. So a lot of people associate high blood pressure initially with medication management, may have some concerns about being on medications forever. Can you talk a little bit about the initial approach to treatment when someone is diagnosed with high blood pressure, and even the role of medications and maybe some other treatment options?
Yes, as we'll soon discuss, this is a very exciting time for raising awareness to hypertension in the United States and beyond, given new therapies for the treatment of hypertension. But when a patient is diagnosed with high blood pressure, the cornerstones really are related to medication and lifestyle intervention. The exciting part about hypertension and bringing our focus back to hypertension, we've known for quite some time it's the leading cause of death in the world. We've known for some time that the majority of individuals with hypertension do not have controlled hypertension. But what's different now is that we also have newer therapies that are also available to patients with poorly controlled hypertension. For the first time in 20 years, for instance, the Food and Drug Administration approved a novel class of medications called endothelin receptor antagonists for the treatment of resistant hypertension. And moreover, we've had the approval within roughly the past year to 2 years of a catheter-based therapy called renal denervation, which is a very safe and effective therapy as a one-time procedure that not only may reduce blood pressure, but may help individuals reduce their medication burden as well.
Thank you for that explanation. So it sounds like if you've got a little bit of elevated elevation in your blood pressure, you've got some treatment options that may be a single medication type therapy. If it's a little bit more complicated, a little bit more resistant, sometimes multi-drug therapy can help. And in cases where it may be not ideal after those treatments, there are now some established procedures that can also help manage blood pressure.
That's exactly right. So when blood pressure is poorly controlled, despite best efforts with medications and or lifestyle interventions, then there has been a new door opened of opportunities with not only renal denervation, but forthcoming new medications as well.
You've highlighted lifestyle several times during our discussion today, and so it's clear that it's important. If I'm diagnosed with high blood pressure and I'm started on a medication and I commit to making lifestyle modifications, is it possible that I may not need to be on blood pressure medication forever?
Very much so. Or perhaps you may be able to reduce the number of blood pressure medicines or the dose of your blood pressure medications as well. And GLP-1 agonists, such as Ozempic, are not antihypertensive medications, but by reducing weight for many individuals, for instance, and put simply and more directly by exercising, watching your diet, and being more attentive to losing weight by more conventional means. Weight loss, for example, is a great opportunity to improve blood pressure control and possibly reduce the need for medications as well.
Most high blood pressure is diagnosed by primary care physicians, maybe seen or managed at that level. When is it that I need to see a specialist, a cardiologist, or even a subspecialist like you?
When blood pressure becomes uncontrolled despite medications, for instance, or perhaps when patients are taking medicine, the blood pressure is still not controlled, and they're seeking alternative therapies, that's an opportunity for more specialized care and referral to, for example, a cardiologist or oftentimes a nephrologist as well.
Thank you. So it sounds like there's a lot of optimism in this space for both patients and treating providers or clinicians. What final thoughts would you like to share with our audience about high blood pressure?
Thank you. We don't know what we don't measure. So the first point is to measure our blood pressure and to track it. And even when blood pressure is less than 130/80 and within normal levels, periodically still individuals should check their blood pressure to make sure that things are not changing for them. Secondly, when individuals do have hypertension, and again, this affects nearly 1 in 2 adults in this country alone, it's very important to treat it and to be effective with treating it. Just taking a pill alone, but still having poorly controlled hypertension, isn't achieving the full benefit and reducing the real risk, because even modest reductions in blood pressure translate to very clinically important reductions in major adverse events that include stroke or heart attack or heart failure or now even cognitive decline. And the last point is that more and more physicians are prioritizing in those clinic visits high blood pressure that's poorly controlled. Not just, Lacey, go home and measure your blood pressure, but let's really get on top of this through your home blood pressure monitoring and greater communication and then referral to other programs that are specialized in the care of hypertension for newer treatment modalities.
Thank you for listening to Living Real Change. To hear more stories from across Piedmont Healthcare, be sure to subscribe and watch for upcoming episodes. For additional health tips, news, and resources, visit us at piedmont.org/living-real-change.